far. I think what we've heard so far is very nicely about the disease and the evidence we have for treating and detecting the disease. And we've heard quite a lot about patients' hopes and patients' fears, although I think we don't know that much about why the patient really decided to do something. But what we also learned, and I think that's gone very clearly, and I'm going to get into this in a second in one more slide, is that we obviously have a problem to get the evidence implemented into the reality. And what we don't really know is 100% why this is and how to overcome this. And I think the image we are trying to paint here is that there's more than efficacy data, so that there are a lot of factors which are at the end influencing the evidence translation, and I hope that we are adding some perspectives on this issue regarding caries treatment. So the question is it done and why not? And I think Sophie told us already quite a lot if it is done, and I think we've already learned that it's not really done. And I want to stick to two examples throughout this presentation, which focus on two problems which we also addressed today. One of the problems is the treatment of proximal lesions, non-cavitated proximal lesions, where we know that we have non-invasive measures, as David showed us, we have micro-invasive measures, I come to that in a second, for example, using caries infiltration or caries sealing proximally, and we have what is the standard in most practices, as we've learned, the invasive treatment. And the question now is, as we've heard from Sophie, what do dentists really do? Would they surgically intervene already at the enamel threshold? And that is data from just another country, it's from Japan, from 2 years ago. And 75% of the dentists said yes, they would do this in a high-risk patient. And the thing is that obviously it's not just the patient, it's not just the lesion, but there are quite a lot of other factors. I don't want to get into that table with you, but quite a lot of other factors like patient's practice setting, or the experience of the dentist, or also his employment status, for example, if he was self-employed or not. So it seems to be a bigger picture which at the end decides what we do and how we do it. And the second aspect, and I think this fits very neatly into what David presented us, is the treatment of deep caries lesions, and Sophie already showed some data. We asked German dentists, what do you do? And more than half of them said, I wouldn't even consider doing stepwise or selective excavation, even knowing, because we asked them, even knowing that the direct capping they would then perform afterwards doesn't have a good prognosis, but they would nevertheless not do it. And we asked them why, and Sophie showed that already. They said, okay, I want to remove all the bacteria, and I want to maintain pulpal vitality. Both things where, from the bacteria side, it doesn't seem to be very important which strategy you perform, because the sealing is obviously more important. And from the pulpal side, you probably fare better off if you don't excavate that deeply. But one thing which was very interesting is that other factors, again, were quite important. Restorative survival, because of guarantee times, was something they cited quite often. And that fits exactly to what your last slide was, and where we have some evidence from Scotland as well. Obviously, reimbursement and a regulatory framework plays an important role in everyday decision-making. So, for decision-making, it seems like efficacy is not that important, because the question, does it work, is the first one we ask. But then we ask other questions, and they are more about appropriateness, about applicability, and at the end, feasibility. How do we get that into practice? So the questions are rather, should we do it, or at the end, and that's probably something we all have in our practices in universities every day, how do we do it? And within this process of decision-making, there are quite a lot of stakeholders, and I think we've addressed nearly all of them today, hopefully, in one slide or the other. We've talked about the patients, and I think what Sophie presented us, and that's also the impression we have from our focus group data and some other survey data, the patients are not the ones who are stepping on the brake there. They seem to trust their dentist quite a lot. And David just told me yesterday evening that the issue of litigation is brought up quite a lot, but I'm not really sure if this is really the case. There is no data about this. But I think the patients are not the ones who are at the moment limiting the evidence translation. We've talked about what the experts, and I would say maybe we in the room here are the experts, so what the scientific data basically says. We've talked about the dentists, and we've learned that they are quite reluctant due to different reasons to implement different strategies. But what we haven't talked about are the payers, and as you would expect, all of these stakeholders come with different perspective on things, and they are looking at different outcomes when they're assessing various treatment. And the payers, they are not looking at short-term efficacy, they're rather looking at feasibility and the long-term benefits, and they are certainly looking at costs, because costs are important, especially in dentistry, as a tool for legitimation. The third aspect, which I want to try and cover in the third part of the presentation, is that they're possibly also looking at equity problem we have is that we have some evidence, but that evidence does not automatically translate into decision making. The long-term effects might be more relevant for decision making than what we have as short-term clinical data. And the last aspect is that cost effectiveness and health distribution are also relevant, but not often investigated in many studies. So the aim of the two studies I want to present you today were to compare the lifetime cost effectiveness of different treatments for carriers, to evaluate the health distributional effects, and to initiate a discussion, stakeholder involvement. And that's what I will present you at the end, because we've got quite some reactions on one of the studies. And as you already probably expected, these aims are pretty big for a clinical trial, because it's nearly impossible to look at very long-term stuff, except for 10 years is already quite long. But the question is what is relevant for carriers. It's a slow progressing disease, and what we should look at is not only the short-term initial treatment, probably also the retreatment and the re-retreatment, because that at the end determines truth loss, it determines long-term costs. So what we did is we looked at it using a modeling perspective and performed simulation studies. And the study type was a cost effectiveness analysis, and the method is basically the same for both the studies I want to present you. We chose to perform that study within the German healthcare system because we know it well, because we have detailed fee item catalogs, and because we Germans worry about the costs quite a lot, as you probably know. The horizon I want to look at in these studies is the lifetime horizon, and that is commendable in one way because it's relevant, but it introduces quite a lot of uncertainty, and we have to admit this because we extrapolate data over a huge period which is not supported by the short-term clinical data, obviously. The perspective we chose for this is the combined perspective of the society and the patient regarding the costs, so what the insurance and the patient would pay together. The transition probability, so for example the probability of a tooth having a pulpar exposure after selective or stepwise or complete excavation, were taken out of mostly systematic reviews and meta-analysis. The costs for these analyses were taken from the German fee catalogs. But then there's one very interesting issue. What is our health outcome? What is relevant to us? And that's not so easy to answer, because a lot of people would say, and medicine is very common, take quality adjusted lifetimes or something like this, so a subjective measure. But the problem is, when we're looking at a single posterior tooth or even 2 or 3 posterior teeth, it might not have a great impact on the subjective quality of life for the patient. So what we looked at in these studies is either how successful are we in avoiding restorations, and this is probably the more important parameter, how successful are we in the long run to retain teeth. And I want to start with the first study which addresses the issue of proximal lesions and what to do with non-invasive or micro-invasive or invasive treatment. And all these studies, they have a model underlying, and I don't want to go into too much detail, I just brought it here so that you can get some overview about it. We start with an E2, so an enamel lesion, or a D1, so a dentine lesion radiographically detected, and it could be treated using non-micro-invasive or invasive treatments. And depending on the success or the probability of a progression, these lesions progress either to E2 and D1 and even further, or if a composite was placed immediately, then the composite was placed immediately, and afterwards you have retreatments, complications, so it's quite a complex network, basically trying to mirror what would happen in the clinic. It is a simplification, but we try to get as much in there as possible to really model the tooth from the beginning, in this case of a 20-year-old patient, a posterior tooth, to the end of the average life of such a male patient in Germany. What was the results? What we looked at first was the number of avoided restoration, or the percentage of avoided restoration, what did it cost? And as you would probably imagine, it's very difficult to compare non- and micro-invasive treatments with invasive treatments if you look at the avoided restoration, because you don't avoid any restoration if you perform invasive treatment. So what we did in the first step is we only compared non- and micro-invasive treatment regarding the cost effectiveness. And you can see this here. You can see the lifetime costs on the y-axis and the proportion of avoided restoration on the x-axis for non- and micro-invasively treated teeth. And as you can see, the non-invasively treated teeth, they generate significantly smaller costs. So the cost gap is quite big for these enamel lesions, whereas the effectiveness advantage is not very big. So obviously non-invasive treatment is quite alright in most populations to arrest such E2 lesions. Yes, infiltration, so micro-invasive treatment is a bit more successful, but obviously this effectiveness gap is not compensating the cost gap. Why is there such a cost gap? It's because infiltration is significantly more expensive than fluoride varnish, which was the non-invasive comparator. Even whilst fluoride varnish is repeated repeatedly applied. So for E2 lesions, one of the things we could conclude from that data is it seems to be, in most cases, seems to be more cost effective to just apply non-invasive treatment, and only in very few cases there will be an advantage if I perform micro-invasive treatment. And I feel that this is data where payers and insurers, for example, might be very interested in. It adds another perspective to what we've heard so far. If we are looking at D1 lesions, the image is a bit different. Here we have a smaller cost difference. As you can see, it's around €100 in average over the lifetime for non-invasive treatment of such a posterior proximal lesion, and around €150 in average over the lifetime for micro-invasive treatment. Why is this? It's not because of different initial treatment costs, because the treatments cost the same regardless of an E2 or D1 lesion treatment. It's because of the effectiveness difference. And as you can see here, in general, we are not that successful in avoiding restorations in D1 lesions because they are progressing quicker. And with non-invasive treatment, only every 4th lesion could be arrested, whilst with micro-invasive treatment, nearly 50% could be arrested. And that is one of the things which are quite important when you perform such a modeling study. You can reflect the retreatment. You can get the costs for the retreatment in there. And I think this is something we often forget when we're talking about treatments. If we look at costs at all, we usually look at the initial treatment costs, but they don't matter that much in many cases because we are looking at 30, 40, 50 years. And that's where the costs at the end are generated. It's by root canal treatment, it's by crowns, it's by implants 30 years later on. And it's nearly impossible to do that in a clinical trial to look at such data. And despite having quite some uncertainty, I think this kind of modeling adds another perspective on these lifetime events. And in my view, the more important comparison is now to compare non- and micro-invasive treatment with invasive treatment, because as we've heard, that's what dentists do. They take the drill and make a filling. And when we look at E2 lesions, we can clearly see that the filling, this is the filling here, this is the infiltration of micro-invasive treatment, and this is the non-invasive treatment. It's significantly more expensive. Why is this? It's not about the initial treatment cost. The initial treatment costs are around €80 in Germany for this therapy and for the filling. It's about the retreatment again. So again, we can really see that the retreatment at the end is determining the long-term costs. And a similar, a little bit smaller, different image here for the D1 lesions, because here, as I said, we are not as effective in arresting them using non- or micro-invasive treatments. So what I would conclude from that study is basically that non- and micro-invasive treatments were shown to be effective also in the long run based on that data. And there's a lot of uncertainty and we can discuss this later on. But they were always less costly than the immediate restoration. And I think this is quite important if we're looking at exactly what we discussed. It's about reimbursement, it's about regulatory frameworks. So the incentives should maybe be overthought if we are looking at the cost effectiveness of the different treatment strategies. And one of the things I already mentioned, obviously the lesion, the patient, but also the healthcare setting may affect our rankings. So we shouldn't deduct our results to other healthcares because in the UK or France it might be different because of different cost structures. And then something which is even more important to me, because I like to talk about deep carious lesions and I like to look at them, and it's also fitting very well to what David Rick has presented us. It's about the treatment of deep lesions and comparing the different carious excavating strategies for deep lesions. It's the same technique, and again we have a model, but now we are already much further into the sequence of events basically, because we already have a deep lesion. What we did is we modeled a molar with a deep carious lesion in a vital tooth in a 15-year-old boy. And depending on which strategy a dentist chooses, we have, as David showed us, a certain probability of pulpal exposure. And I can already tell you that the pulpal exposure is at the end the most important thing for the cost effectiveness. Because what happens, if you don't expose the pulp, everything is fine. You place a composite and that's it. But if you do expose the pulp, you perform, in most cases, direct capping. And as we've heard, direct capping does not have a great success rate, so it will need retreatment quite early on. And the retreatment usually would be root canal treatment. And the root canal treatment, in many cases, would then receive a crown afterwards, which is standard, for example, in Germany in most patients. So at the end, the root canal treated tooth would maybe need a retreatment, again, surgically or non-surgically, and a root canal treated tooth which doesn't work out even after surgical retreatment would need removal. So again, by only excavating a carious lesion, which is an everyday step for thousands of dentists every day, we get into this process very quickly. And we are igniting that spiral of the tooth very swiftly. And that is also reflected by the cost effectiveness data of our study here. When you look at the three comparisons, you can clearly see that blue is the complete excavation. It is significantly more expensive and significantly less effective because of mainly the pulp exposures. By exposing the pulp, you shorten the lifetime of